Brooks Tingle is the President and Chief Executive Officer of John Hancock Insurance. He's implemented John Hancock, is it Vitality? A savings and reward system for beneficiaries that incentivize healthier living and healthier behavior. Ed Clark is Vice President and Chief Medical Officer of the Banner Insurance Division, the Insurance Division of Banner Healthcare Systems. His work in clinical medicine and population-based payment system models informs his perspective on physician-led cost containment strategy. Mr. Ovik Roy is co-founder and chairman of the Foundation for Research on Equal Opportunity, identifying promising biotechnology companies for Bain Capital, advising 3 presidential campaigns, and founding the influential healthcare policy blog, The
Apothecary.
Okay, that's what I thought this was. The Apothecary has informed his extensive views on healthcare system. I would now, that you've been introduced, Mr. Tingle, you have 5 minutes. Please share with us.
Good afternoon, Chairman Schweikert, Ranking Member Hassan, and members of the committee. Thank you for the invitation to participate in today's hearing. I am Brooks Tingle, President and CEO of John Hancock. Earlier this year, I testified before the House Ways and Means Subcommittee on Health, and I am pleased to be here today with the Joint Economic Committee to continue the conversation about a topic I'm deeply passionate about. John Hancock offers a range of financial services products, but I'm going to focus today on our life insurance business and the innovative approach that we're taking to help our customers live longer, healthier, and better lives. It's a different model than you may be familiar with, but one we're proud to be leading. Simply put, life insurers make money by collecting premiums, investing those premiums, and then sometime down the road, we pay a claim. Generally, the longer a customer lives, the longer those funds stay invested, and frankly, the more the insurer makes for profit. So on economics alone, the math tells us that the life insurance industry should have a vested interest in their customers living longer, healthier, and better lives. Given this alignment of interests, it struck us as quite odd that the industry had done very little to help our customers try to improve long-term health outcomes. So we set out to do something about that. And this year marks the 10th anniversary of John Hancock Vitality, our behavioral science-based program that offers our life insurance customers tools, resources, incentives, and rewards to help them improve their health. Quickly, I'll share how it works. Using an app, customers who choose to participate can earn points for everyday activities that correlate with better health, from a good night's sleep and daily exercise to things like meditation, regular physicals, buying fresh produce, taking part in early detection screenings, and more. Those points add up to a status level, bronze, silver, gold, platinum, and that status level then drives 2 really important things for our customers. 1, the level of premium discount they enjoy on their life insurance premium. And 2, the value of a range of discounts and rewards from a variety of program partners, including discounts on healthy foods, travel, and much more. So over the past decade, we've seen our members do some pretty amazing things. 1, engage regularly. Many of our members are engaging with the app and the program 20 to 30 times a month. Next, we've seen our members and our customers become more physically active. Our life insurance customers participating in Vitality take, on average, twice as many steps as the typical American. And then 80% report similar or improved health, including 52% with high blood pressure, bringing readings within a healthy range, 45% reducing BMI, and 63% bringing their cholesterol within a healthy range. We continuously enhance Vitality with the latest tools and technology to help our customers better understand their health and make informed choices. Most recently, we have focused on innovations in early detection. We were the first life insurer to offer discounted access to GRAIL's Gallery multi-cancer early detection test and Prenuvo's whole body MRI scan. Collaborations with these leading-edge companies have undoubtedly helped save lives. Customers have detected cancer and other conditions earlier than they otherwise would have likely leading to much better outcomes. We appreciate the support of members of this committee for the multi-cancer early detection Medicare bill and hope it crosses the finish line this Congress. Life insurers are uniquely positioned to engage customers over the long run because our relationships span decades. It's not uncommon for one of our customer relations or for our customer relationships to average 30, 40, 50 years. That longevity gives us the opportunity to realize the financial benefits of investing in prevention and early detection, and to help achieve better health outcomes at scale for more Americans. After 10 years, here's what we know. Properly designed programs can improve health outcomes at the population level. Education matters, but pairing it with incentives and rewards drives even better results. Advances in personal health technology, wearables and such, are critical to success. And yes, gamification works. Even with the opportunities to save lots of money on their premiums and enjoy other discounts and rewards, the program feature that we most commonly get great feedback on is a game where every 10th workout you complete, you get to spin a wheel that looks like the Wheel of Fortune, and you win small little prizes, but people love the wheel. So gamification works. As this committee knows well, the U.S. population, age 65 plus, is projected to surge from 58 to 82 million by 2050, and 1/5 of an individual's life, on average, is now expected to be in a state of illness, while almost 4 in 10 people will face financial instability as they age. This has huge societal costs, and we must reimagine the future of longevity and aging. One way we are working to address these challenges is through a collaboration with the MIT Age Lab on a new annual Longevity Preparedness Index, which you can read about fully in my written submission. In conclusion, our model of incentivizing and empowering individuals towards better health can and should have broader application, and the life insurance industry is well positioned to play a bigger role in these important public-private partnerships. We look forward to working with policymakers in the common pursuit of helping Americans spend more years in better health. Chairman Schweikert, Ranking Member Hassan, members of the committee, thank you for your time this afternoon, and I welcome your questions.
Good afternoon, Chairman Schweikert and Ranking Member Hassan. Thank you for holding today's hearing. Stop paying more for less, realigning healthcare incentives to improve outcomes and reduce cost. I applaud you for taking time to examine this important issue. My name is Ed Clark. I currently serve as the Vice President and Chief Medical Officer of Banner Health Plans and Networks, an integrated and population health organization of Banner Health, one of the largest non-for-profit health systems in the country. My team and I lead clinical strategy, quality, and value-based performance for over 1.2 million covered lives spread across multiple states. This spans commercial, Medicaid, Medicare Advantage, and all of our accountable care programs. It would be an understatement to say that integration is key for a complex system such as ours. Having 2 distinguished members of Arizona's delegation assigned to this committee, I would be remiss if I didn't also highlight a few state stats making this integration more paramount. For example, Arizona is the 14th most populous state and the 6th largest by size. We are one of the fastest growing states as well, with over 2 million new residents since 2000. Commensurate with this growth, our senior population is up 48% over the last decade. That means 17% of Arizona's population is currently on Medicare and growing. Given these statistics, coupled with our vast geographic terrain, it's my job to align physician incentives with the organization's overall mission. What are the drivers behind those incentives? Quality, affordability, access, and total cost of care reduction, all of which are equally weighted. Our physicians have evolved their focus from thinking, what do I need to do during this patient encounter, to what do I need to anticipate for this patient tomorrow, next week, next month, next year, to keep them healthy. One of our most strategic decisions occurred with the assumption of risk, a very different value proposition from our initial roots as a hospital delivery system. Being an integrated and population health organization requires coordinating care and coverage. And it can only succeed if there's ample primary care provider participation and frequent intervention with patients. What's the economic engine holding these units together? The answer is premium-based payment. Upfront capital provides a means for investment, not only in our patients, but also in our clinicians, the teams, and the systems around them. It's what allows us to drive change if we are able to keep pace with Arizona's economic growth projections. An early adopter of electronic health records, we harness these data combined with claims information to create dashboards that track our managed population's outcomes, allowing us to plan a patient's next best intervention as part of our integrated approach. It supports clinical decision-making by tracking screening events, preventive visits, pharmacological data, patient entry points, and emerging therapeutic trends despite workforce shortages, community health demands, supply chain interruptions, and other challenges. With 10,000 Americans becoming eligible for Medicare each day and trust fund insolvency on the horizon, we want to take our years of risk assumption plus our value-based experience and pilot a Medicare Advantage demonstration. We partnered with CMS on these types of endeavors since 2012. To help quantify the partnership, it's generated over $240 million in savings to the federal Medicare program while attaining quality scores in the top 2% of the country. We're part of the Advanced Track Medicare Shared Savings Program, which involves a top tier of financial risk, but it's time to go to the next level. The keys to unlocking financial performance and improved patient care are not simple, but they are achievable, however, and ready to scale with federal support. These keys include premium-based payment, seamless enrollment, team-based care, early intervention, optimal use of healthcare technology, reinsurance thresholds for catastrophic cases, and a counter-based risk adjustment. Driving these types of investments further, premium-based payment also avoids duplicative testing and maximizes frequent and continuous primary care team visits while minimizing high-cost sites of care such as ER visits, unlike in our current fragmented fee-for-service system. Understanding the population profile ahead of time is critical via data sharing. This way we can match the illness burden demand to the primary care team supply. And last, investing in emerging technologies allows clinical teams to engage and monitor patients while at home, supporting well-being and other indicators of health. These are some of the features needed to realign care. We look forward to working with you on new models of care, especially as it relates to Medicare Advantage. The optimal result, better alignment, better outcomes, and better management for the total cost of care. Thank you, Mr. Chairman and members of the Joint Economic Committee for calling this important hearing. I'm honored by the invitation and look forward to answering your questions.
Chairman Schweikert and Ranking Member Hassan and members of the committee, it's truly a pleasure to testify before the JEC. The Foundation for Research on Equal Opportunity, or FREOP for short, is a nonpartisan think tank dedicated to improving the lives of Americans on the bottom half of the economic ladder using freedom, innovation, and pluralism. I've always felt a kinship with the JEC as FREOP's very first policy scholar, Scott Winship, served as executive director here a few years back. We all know that American healthcare is costlier than that of other wealthy countries without better outcomes. Many theories have been offered as to why. Almost all of them are wrong. First, let's review the data. Each year, my organization produces the most comprehensive assessment of the performance of U.S. healthcare in comparison to that of 31 other countries with the highest GDP per capita and a population over 5 million. We call it the World Index of Healthcare Innovation, or WIHI. In the 2024 WIHI survey, the U.S. ranked 7th overall, first in science and technology, but dead last in fiscal sustainability. On more detailed measures, we ranked 22nd on disease prevention and last on affordability of health coverage. Some argue that the U.S. has a free market healthcare system, and that is why American healthcare is so expensive. But nearly half of U.S. healthcare spending is government spending. Indeed, on a per capita basis, no country subsidizes healthcare more than we do. In 2022, the U.S. subsidized nearly $7,500 of healthcare per person compared to $3,100 in the other WIHI countries. Furthermore, there are nations with healthcare systems that are more free market oriented than America's, like Switzerland and Ireland, with lower costs and better outcomes than ours. In the WIHI survey, Switzerland and Ireland rank 6th and 1st, respectively, on disease prevention. Others argue that fee-for-service healthcare is the primary culprit of high costs and poor outcomes because, it's said, charging patients this way incentivizes doctors and hospitals to prescribe more services to make more money. But many other advanced nations use fee-for-service payments and spend far less on healthcare, including Canada, Japan, France, and Germany. Indeed, several widely cited studies show that the volume of healthcare utilization in the U.S. is lower than that of other industrialized countries, but that unit prices of healthcare here are far higher. The single biggest driver of high U.S. healthcare costs, the original sin of U.S. healthcare, turns out to be the decision in the mid-20th century to exclude the value of employer-based health insurance from all taxation. The problem is not that Americans experience third-party payment for healthcare services through insurance. That happens all around the world. The problem is that Americans experience third-party payment of insurance, that is to say, third-party payment of third-party payment of healthcare, effectively ninth-party healthcare. On an after-tax basis, for every dollar a worker receives in wages, the same dollar used for employer-sponsored health insurance is worth $1.51. Over 8 decades, this massive tax subsidy has driven American healthcare prices skyward. Workers have no transparency into how rising healthcare prices depress their wages. Employers and insurers have little incentive to control costs or make their workers healthy. And we constantly demand more services be covered by health insurance in a way we would never demand of car insurance or homeowners insurance because of the tax subsidy. We could fix these problems and many others to boot by using the Swiss model as a vision for a freer, healthier, and more fiscally sustainable system. Switzerland has universal coverage, but there are no government insurers. Everyone individually buys their own private sector plan and takes it from job to job, independent of their employers. The Swiss has many similarities to Medicare Advantage and the ACA's insurance marketplaces, but also some useful differences, especially in terms of incentivizing enrollees to be healthier. I'm happy to discuss these during the Q&A session. I appreciate that the hot topic of the moment is what to do about Obamacare. I've been writing since 2010 in great detail why the ACA's flawed design would lead to higher premiums, not lower ones. I'm very sorry to have been proven right. Silver premiums have nearly tripled and deductibles have more than doubled since the law went into effect in 2014. But it's not enough to criticize Obamacare. There is no future for free market health care without a vibrant, affordable market for individually purchased health insurance. The good news is that there are bipartisan ways to reduce Obamacare's underlying premiums before subsidies are taken into account. Obamacare made coverage unaffordable for the young and healthy uninsured, driving them out of the market and raising premiums for all those who remain. We can fix these problems with 5-to-1 age bands, reinsurance, and other tools I describe in my written testimony. We can dramatically enlarge the market for individually purchased health insurance by helping employers offer workers cash to buy their own coverage and by migrating federal employees onto the ACA exchanges. I'm eager to work with any and all members of Congress from both parties to bring these ideas to fruition. Thank you.